So we're going to talk about obstetrical complications in this high-risk OB portion of your class. Alright, so we're going to talk about in antepartum, during intrapartum, and the postpartum period. We're going to cover all of those periods. This is just a picture of an anatomy of a pregnant woman. On the following slides, we're going to discuss fetal diagnostic procedures that are done in the antepartum period. So in the next couple slides, we're going to discuss a non-stress test, a contraction stress test, and a biophysical profile. So with the non-stress test, alright, so the purpose of a non-stress test is to identify whether an increase in the fetal heart rate occurs when the fetus moves, which will indicate, here's this term, this theory that I've drilled into you guys' head, is adequate oxygenation to the fetus. Okay. It also tells you that there's a healthy neural pathway from the fetal central nervous system to the heart and the ability of the heart to respond to stimuli. Okay. So the procedure of a non-stress test is when it's external monitoring only. The fetus is not challenged or stressed by contractions in any way to obtain data with this test. So when you have the interpretation of an NST, or a non-stress test, you want it to be reactive or reassuring. Those two words are kind of used interchangeably. You want to have at least 2 fetal heart rate accelerations with or without fetal movement occurring within a 20-minute period. Okay, we want those 2 fetal heart rates to be 15 beats by 15, so 15 beats above the baseline, and it has to last for at least 15 seconds. Okay, and that is for anyone over 32 weeks pregnant. If it's under 32 weeks pregnant, we use the 10 by 10 rule. 10 beats per minute above the baseline, lasting 10 seconds. So a non-reacting or non-reassuring NST is when the tracing does not demonstrate the required characteristics of a reactive tracing within a 40-minute or longer period. So basically what this is saying, you're not getting those 2 accelerations of 15 by 15 within a 20-minute window. So sometimes when a lady first gets there and you put her on the fetal monitor, maybe that baby's kind of sleepy at first, or maybe she has a really big acceleration right at first. Well, then baby goes to sleep and then she doesn't have another acceleration until 30 or 40 minutes later. That doesn't count as reactive because the 2 accelerations have to be within 20 minutes of each other. Okay, so do keep that in mind. And then, so we will give them sometimes even 40 minutes up to an hour to try and get that baby to wake up. If after an hour you can't get a reactive NST, then we'll usually call the physician and possibly order, another form of testing. So next we'll talk about a contraction stress test, or a CST. This is done, one of the things you can do if you have a non-reactive, non-stress test, you can always choose to do a CST, which is a contraction stress test. Okay, so you're going to be concerned if you do this test. This isn't your first choice to do, but you're going to be somewhat concerned or want to make sure that this baby's okay. So your concern would be that fetal oxygenation is only marginally adequate and will be decreased further with contractions. So you need to stimulate contractions with this test. Of course, you aren't going to do it in someone that's less than, that 37-week period because you don't want to throw them into preterm labor. Okay, if you're concerned about someone who's in that preterm period, you would probably go on to a different test where you don't have to stimulate contractions. But if they're term, this test works appropriately. 2 ways to stimulate uterine contractions is with nipple stimulation. The woman can rub or roll her nipples, or you can start an IV and give her Pitocin. Okay. Results: a positive test means that the fetus is showing some stress in relationship to contractions. So the baby's having some kind of decelerations in relationship to the contractions. A negative result on a contraction stress test is reassuring. So on this slide we're comparing a non-stress test to a contraction stress test. So with a non-stress test, we want to see it be reactive or reassuring. You need to have a minimum of 2 fetal heart rate accelerations that occur within a 20-minute period. Those accelerations have to be 15 beats and last for 15 seconds. So 15 beats above the baseline is what that means, and lasting for 15 seconds. Those type of accelerations or movements, at least, again, 15 beats above the baseline that lasts at least 15 seconds. If it's non-reactive or non-reassuring, that does not demonstrate reactive tracing within 40 minutes period. Sometimes we give them up to 60. I should probably change that, 40 to 60 minutes or longer. So that doesn't necessarily mean that you're seeing something bad. It just means that you're not seeing the above 15 by 15. Okay? Sometimes babies just don't move a lot when we're doing the NST, and then we send them for further testing and they're perfectly fine. So that's the limitations of a non-stress test, okay? So, but if you do a contraction stress test, a negative one is what is reassuring on a contraction stress test, okay? So that means there's no late or significant decelerations in relationship to a contraction. A positive one is non-reassuring, okay? That's usually you're going to see late decelerations in more than 50% of the contractions, all right? So with a CST, you have to have a 10-minute window, and you have to have 3 contractions in that 10-minute window to be able to run this test, okay? Or to be able to define it as negative or positive, all right? It definitely would make you suspicious of intrauterine placental insufficiency. You could have hyperstimulation, which you don't want, and it could be unsatisfactory. The tracing cannot be interpreted. Maybe there's something, but it's not quite, you're still questioning what it looks like. Then again, from there you would go to probably the biophysical profile, which we'll talk about next. So a biophysical profile. A biophysical profile is basically an ultrasound. It has 5 components. So it has 4 parts of 4 of the 5 are with the ultrasound, and the 5th one is the non-stress test. Okay, so as you can see in this chart, here's the 5 components: fetal movement, fetal tone, fetal breathing, and then it measures amniotic fluid. All right, each one of these components is allowed either 0 or 2 points. It is either there or is not there. So they should be able to get 2 points for each, each one of these categories. It's never an odd number, so you can never get just 1. All right. If a lady is going in for her biophysical initially, before she has a non-stress test and she gets an 8 out of 8, they don't always require them to come back upstairs and do the non-stress test. Okay. Because if they get 8 out of 8, it tells us that everything's really good as far as uteral placental sufficiency, that type of stuff. Now, if she comes up for a non-stress test and doesn't pass her non-stress test, and we don't see anything significantly bad, but we just want to find out, well, what's going on with this baby? Why didn't, he or she pass its stress test, its non-stress test? Then they will send her down for a biophysical profile. Now, because she did not, pass her non-stress test, she'll get a 0 for that category, but she might get 8 out of the other ones. So she might get an 8 out of 10, which is perfectly acceptable for a biophysical profile. On this slide, we'll talk about amniotic fluid abnormalities. All right. So the first one is oligohydramnios. This is defined as a reduced amount of amniotic fluid. So, and you don't have to know these measurements, but an example is if there's an amniotic fluid index, which we call AFI, of 5 centimeters or less, or the deepest vertical pool is less than 2 centimeters. That would be oligohydramnios. All right. Polyhydramnios which is also known as hydramnios, or sometimes we just call it poly. Either one. It's defined as an excessive amount of amniotic fluid of 2,000 mils or more. So you would have an AFI of greater than 25 centimeters, or the deepest vertical pool of greater than 8 centimeters. All right, and again, all of these are measurements at term. So here we're going to discuss the oligohydramnios. Okay, it talks about it is an abnormally small quantity of fluid, less than 500 mils. Again, this is at term. Is associated with poor fetal lung development and malformations that result from the compression of fetal parts. This can occur because the kidneys failed to develop, urine excretion is blocked, or placental blood flow is inadequate. This finding may indicate chronic fetal hypoxia and warrants more frequent biophysical profiles or the consideration of delivery. Hydramnios, or also known as polyhydramnios. This is when you have the quantity of amniotic fluid may exceed 2,000 mils at term. This finding may occur when the fetus has a severe malformation of the central nervous system or GI tract that prevents normal ingestion of amniotic fluid. So the next couple slides are going to be discussing amniocentesis. Amniocentesis. This is when you take an aspiration of amniotic fluid from the amniotic sac through examination. You do go through the mother's abdomen to get to the amniotic sac. The earlier you do an amniocentesis, the more chance you have of risking a fetal loss. An amniocentesis performed in the second trimester, so somewhere between 15 and 20 weeks, is typically testing for fetal chromosomal anomalies. An amniocentesis in the third trimester, you will be testing for fetal lung maturity. So again, an amniocentesis. So an amniocentesis done in the second trimester is to examine fetal cells to identify chromosomal or biochemical abnormalities. It also evaluates if a mother is sensitive to Rh positive blood, if there is an amnionitis, and if the serum alpha fetoprotein is abnormal. So elevated levels can be indicative of a neurotube defect like anencephalic or spina bifida, and low levels are usually associated with chromosomal abnormalities like Down syndrome. So an amniocentesis done for fetal lung maturity is, of course, only done in the third trimester because there's no way a baby's lungs will be mature in the second trimester. Okay, so what we're measuring is the LS ratio, the lecithin-sphingomyelin ratio. So lecithins and sphingomyelins are lipoproteins that make up surfactant. Surfactant keeps the alveoli open by reducing surface tension on the inner walls. And I know you guys have learned this, I've drilled this into your heads, but this is good. So it's just reinforcing what you've learned, okay? So the decreased surface tension prevents collapse of the alveoli when the infant exhales, reducing the effort of breathing. So obviously the surfactant is a good thing. An LS ratio of greater than 2:1 generally indicates that surfactant is adequate and the fetal lungs are mature. At approximately 30 weeks gestation, the LS ratio is equal, but after that, after the 30 weeks, the lecithin continues to increase. And remember, this ratio may not be accurate with a diabetic mother. All right, there's lots of reasons that changes. The glucose and the insulin plays a factor in that, but just kind of keep that in mind. It also is related to, in case there's been any kind of preterm labor or anything like that, if mom has gotten any of the beta-methazone, that will also affect the LS ratio. So this slide just shows a visual of how an amniocentesis is done. Notice at the very top of the picture, see the ultrasound that is on the top of outside of mother's abdomen, because when you do this, of course, you do not want to put that syringe and needle through the placenta. So you need to know where the placenta is. That's why the ultrasound has to be available and in use during an amniocentesis. And on this picture, you can see the placenta is down under the baby's back. All right, so they pick a place to go through mother's abdomen and find a big pocket of fluid where there hopefully is no cord or placenta or baby parts at that point. The picture on the right, it just shows it goes through the skin, all the way through the uterine wall and into the amniotic sac. Withdraw a couple cc's of fluid, and then that needle comes out directly. And that's the procedure. So this is just a slide that talks about some maternal hemodynamic changes. I'm not going to go over every one of those, but just remember the total blood volume increases by about 30 to 50% during a pregnancy, and that's approximately 1,200 to 1,600 extra mils in that woman's body. Extra blood volume is needed to transport nutrients and oxygen to the placenta and to meet the demands of the expanded maternal tissue in the uterus and breasts. The greater volume also provides a reserve to protect the pregnant woman from the adverse effects of the blood loss that occurs during childbirth. Alright, so on this slide we're going to discuss hyperemesis gravidarum. This is when a pregnant woman, okay, it's only with pregnant women, they have persistent uncontrollable vomiting starting in early pregnancy that can lead it can continue throughout their entire pregnancy possibly. It can lead to dehydration, electrolyte imbalances, weight loss, elevated ketones, eventual hepatic and renal dysfunction are also possible. This may continue throughout the pregnancy. It is defined as a weight loss of more than 5% or more of a pre-pregnant weight. One thought process on this, when a woman gets it, that there could possibly be an allergy to fetal proteins. And the newborns could reflect a low birth weight also, if mom continues to be sick throughout her whole pregnancy. So think about what kind of assessments you would expect on these women. They're going to have decreased fluid intake and decreased urinary output. They'll have an increased urine-specific gravity, they'll have dry skin and mucous membranes, and decreased bowel movements with a harder consistency because they're not keeping any fluids down. Remember, nursing interventions, you want to focus on reducing nausea and vomiting and maintaining nutrition and fluid balance, and always provide emotional support to these ladies. So treatment for hyperemesis, it's usually done in an outpatient setting. If a patient has a severe case, we will admit her and keep her longer than just overnight. IV fluids are the key, of course. You're going to monitor her lab results, do an I&O on her, especially if you're keeping her for a significant amount of time. Supplements, emotional support, antiemetics, and any other methods to control or decrease her nausea and vomiting. Very, very important. So when I talk about emotional support, it's so extremely important. Some of these women literally are vomiting for almost 8 months straight when they have it really, really bad. And by the end of, towards the end of that pregnancy, they're having a tough time, really tough time, handling what's going on to them and their bodies. So they really, really need that extra emotional support. It doesn't seem like it would be that big of a deal, but it does take a toll on these ladies. Next, we're going to talk about hemorrhages in early pregnancy. We're going to talk about abortion, whether they be SAB or TAB, ectopic pregnancies, and hydatiform moles. These are the 3 most common causes of hemorrhage and potential pregnancy loss in the first half of pregnancy. Alright, so first we'll talk about spontaneous abortion. This denotes a termination of a pregnancy without action taken by the woman or any other person. So basically what we're talking about is a miscarriage. It's another term for a spontaneous abortion that occurs spontaneously as opposed to one that has been induced. And most of these occur in the first 12 weeks of pregnancy. This slide just shows the different classifications of the different types of spontaneous abortions. There is threatened, inevitable, incomplete, complete, missed, and reoccurrent. Let's see. Remember, a spontaneous abortion is one that typically happens in the first 12 weeks before there's any signs or symptoms of pregnancy. Most often it happens due to congenital anomalies or abnormalities, infections, or endocrine disorders. So this slide will talk about threatened abortion and inevitable abortion. excuse me. With a threatened abortion, you will have vaginal bleeding that is occurring. This does not always end in a loss, but it's a threatened AB. Okay? And again, these will usually occur in the first 12 weeks. With a threatened AB, the HCG will be decreased, but again, it doesn't always automatically end in a loss. An inevitable abortion is when membranes rupture and the cervix dilates. Okay? You may have active bleeding, will be present and heavy. There will be natural expulsion of the uterine contents, including fetal tissue, also known as products of conception. Sometimes these women will need a D&C, and then this can turn into an incomplete AB also, which is why they have to go and have a D&C. Some of the products stay in the uterus, they remain in there, don't get expelled, and that causes bleeding, which obviously you don't want that to continue, so you do have to go in and do that D&C to get rid of those contents. This slide just shows levels of HCG, human chorionic gonadotrophin. Okay, remember these levels increase as the pregnancy progresses, and they increase quite significantly, as you can see, each week. Incomplete abortion. This is when some products of conception have been expelled, but some remain. Maternal signs and symptoms: there will be active bleeding and severe cramping. Retained tissue will prevent the uterus from clamping down and resulting in profuse bleeding. Management of care for these women: IV fluids, type and screen. Progesterone may help stabilize things, but definitely a D&C to scrape out the contents of the uterus to get so that bleeding stops, so that uterus can start clamping down and the bleeding slows down. A complete spontaneous abortion is when all contents are expelled and there's no further interventions required. Management for a complete is just rest, watch for increased bleeding, watch for fever, encourage vaginal rest, and emotional support. And again, remember that component of this discussion here about losses is so very important with our patients. So a missed AB is when the fetus dies in the first half of the pregnancy but remains in the uterus, when the body doesn't expel it. The signs and symptoms of pregnancy disappear, the uterus stops growing, and it's usually found during an ultrasound. Complications are infections and hemorrhage, and the management of this, again, is a D&C. A recurrent loss is when a patient has had 3 or more consecutive spontaneous abortions or losses. Management: the physician will examine the reproductive organs, hormones, cervical incompetence, possibly do some genetic screening, that type of stuff, to see if they can figure out why this couple or this woman continually is experiencing these losses. So nursing considerations during these spontaneous losses. Things you want to pay attention to is bleeding, potentially a lot of bleeding. You want to monitor how much she's having. The vital signs, of course, you want to pay attention to the blood loss, the hypotension, the low blood pressure, increased pulse, clammy skin. Eventually, if you don't take any action on that, they're going to decrease their level of consciousness, potentially go into shock. So that's all things you want to avoid. Other things you want to pay attention to is infections. It's greatest in the first 72 hours after a SAB and surgical procedures. Of course, you want them to only use pads, no tampons, good hand hygiene, etc. You want to monitor their labs, hemoglobin, hematocrit, and pay attention to their RH factor. It's a huge reminder in this loss period. Not everyone will think to look at the RH factor for these women. If they're RH negative, they should get a shot of Rogam. Proper nutrition, high iron, vitamin C, increased protein and fiber, and just lots of psychological support. As nurses, you should convey unconditional acceptance of their feelings, provide information and simple, brief explanation of what has occurred and what will be done. Grief may last up to 6 months to a year. Do not minimize this experience for these patients. It is very real for them. And of course, everyone deals with grief and loss differently. So next we'll talk about ectopic pregnancy. This slide shows different parts of the fallopian tube that the fertilized ovum can implant into, okay? And basically where it should be traveling into the uterus, and sometimes it implants. And you don't have to know these sites or anything like this. This is just an FYI. But ectopic pregnancy is implantation of the fertilized ovum that is outside of the uterine cavity. Signs and symptoms are abdominal pain and vaginal bleeding. The incidence of ectopic pregnancy has increased dramatically over the last 20 years due to the growing number of women of childbearing age who experience scarring of the fallopian tube caused by PIDs, secondary to STIs, IUDs, previous ectopic pregnancies, surgeries from reversed tubal ligations. You will have decreased HCG and progesterone levels, which will suggest an abnormal pregnancy. So again, one of the biggest signs with an ectopic is abdominal pain unrelated to anything else. Sometimes the woman doesn't even know she's pregnant yet when she starts having some of this abdominal pain, and we'll show and talk about this on some future slides here. So this slide talks about ectopic pregnancies. On the top left you can see a normal fertilized ovum inside of the uterus. Okay. On the right top you can see the ectopic pregnancy where the ovum is, the fertilized egg is, it stops its implantation in the fallopian tube there. Okay. Down below on the left you can see what a specimen actually looks like, and on the right is a animated drawing of eventually that fallopian tube rupturing from that egg growing, which is a normal process. Okay, so when anytime a woman comes in and if they are reporting shoulder and neck pain, that can be signs of a ruptured tube to irritation of the diaphragm. Okay, there's two ways to remove a ruptured or an ectopic pregnancy. One is a salpingostomy. This is a lengthwise cut of the tube, and the ectopic growth is expelled and the tube is left to close by itself to reduce scarring, to salvage the tube for future pregnancy. There's a salpingectomy, is when a portion of the tube is removed and reconnected with the healthy part. And then there's also always where they just have to remove a tube totally because it's either ruptured, too injured, whatever. The goal with the ruptured tube is to prevent hypovolemic shock, control pain, and give these ladies emotional support. Next we're going to talk about the hydatidiform mole. This is also known as gestational trophoblastic disease or a molar pregnancy. This is when you have trophoblasts that develop abnormally and only the placenta develops, not the fetus. This is usually diagnosed by the 4th month. You'll have high levels of HCG due to the rapid proliferation of the abnormal chorionic villi. Okay, so hydatidiform mole can have malignant changes and proliferation of residual trophoblastic tissue. This is a life-threatening complication. It is imperative to avoid uterine stimulation since contractions can cause trophoblastic tissue to be drawn into the venous circulation and travel to other organs, causing the choriocarcinoma. So this gestational trophoblastic disease may undergo malignant change with rapid spread to distant sites such as the lung, which is the primary, vagina, liver, kidney, and brain. So management of the hydatidiform mole is it includes evacuation of the mole, followed by curettage, a DNC to remove all remaining molar tissue with a follow-up to detect any malignant changes in any of the remaining trophoblastic tissue. So follow-up protocol is crucial to detecting malignant changes of the remaining trophoblastic tissue. This involves weekly HCG levels until 3 normal pre-pregnancy levels are attained, followed by monthly levels for a full year. The client should avoid pregnancy at all costs during this initial year, so birth control is definitely encouraged. This slide talks about hemorrhage in late pregnancy. We'll be discussing placenta previa and placental abruption. So first we'll talk about placenta previa. There's 3 different types. There's marginal, partial, and total. They are defined by the location of the placenta. It is where the implantation occurs, depends on how you classify it. So a marginal placenta barely extends to the cervical os, as you can see down below here. A partial placenta partially covers the cervical os, and total is where the placenta totally covers the cervix. So placenta previa, the marginal, is where it implants in the lower third of the uterus, but its lower border is greater than 3 centimeters from the internal part of the cervical os. The partial placenta previa, the lower border of the placenta is within 3 centimeters of the cervix but does not fully cover it, and a total is when the placenta completely covers the cervical os or opening. Treatment of placenta previa, medical interventions are based on the condition of the mother and the fetus. Conservative management is recommended. Signs and symptoms of a placenta previa, of course, is the painless vaginal bleeding. Okay, so when we talk about medical interventions are based on the condition, if mom is not showing any active bleeding, then you just keep her on bed rest and watch things closely. Of course, if she starts bleeding, you have to monitor fetus and mom and make decisions from how much bleeding is occurring. Next, we're going to talk about abruptio placenta, or a placental abruption. You can classify it or call it either way. This occurs when there is bleeding and the formation of a clot/hematoma on the maternal side of the placenta. So the clot can grow and impair fetal gas exchange. So see the top picture here, it's a marginal abruption, and this one has external bleeding, so the lady would experience some bleeding. Okay, see there's part of the placenta is not attached to the uterus, but part of it is. Okay, on the next one is partial abruption, and this is when there's just a small little area of concealed bleeding that stays behind the placenta. It doesn't get expelled out. The lady doesn't always know, other than maybe she's having some irritability, some cramping in her uterus. Another abruption is a complete abruption, and there could be concealed bleeding, but eventually that bleeding will come out. So any of these 3 are different types of placenta abruption. So what makes a woman at risk to have an abruption? Cocaine use, maternal hypertension, these 2 are both related to vasoconstriction, abdominal trauma, history of abruption, multa gravida, or smoking. So classic signs with an abruption, there could be vaginal bleeding, but it's always associated with some kind of pain. They can have abdominal low back pain, uterine irritability, low intensity contractions. There could be a high uterine resting rate or just some uterine tenderness. The uterine tenderness is usually at the site of the abruption. The whole abdomen may be hard and tender. The patient will be restless. And again, remember, the hemorrhage can be concealed, so you may not see any active bleeding, but she could be bleeding a large amount behind that placenta. So if a patient comes in with the diagnosis of a placental abruption, the 2 major concerns are excessive bleeding and fetal hypoxia, of course. So you want to always assess vital signs on mom, her level of consciousness, her urine output. Fetal monitoring is obviously a high factor, a high priority with an abruption. You want to put her in a lateral position, head of bed flat, put her on her side, anticipate fluid bolus, So you're going to always get in 2 large bore IVs on this lady, and most likely prepare her for a cesarean, depending on the extent of the abruption. If it's just a partial one, we don't always do anything as long as baby's looking good on the fetal monitor. But if baby is showing any kind of hypoxia, low fetal heart rate, major decels, anything like that, then we need to get her delivered sooner than later. Okay, we are going to run labs on her, of course, a CBC, type and cross match, RH factor, a KB test, coag studies, and any kind of drug screen. The KB test, that checks for fetal red blood cells in the maternal circulation to know sometimes what dose of RhoGAM is needed. They don't really use that a whole lot, but that's just an FYI for your knowledge. Okay. Alright, so if we have a patient that comes in with vaginal bleeding, we never ever do a vaginal exam on them. And why is that? Because if you have a placenta previa, a total one that is covering that cervix, and you go to do a vaginal exam on that, a cervical exam on her, and you stick your fingers up in there and put a finger through that placenta, then you're going to cause massive hemorrhaging at that point, and you would have to get that baby delivered immediately. So again, you always need to look at any type of imaging that woman has had before you ever do an exam on any pregnant woman when they come in labor, especially if they have some vaginal bleeding. So next we're going to discuss hypertension during pregnancy. Some of the different classifications is gestational hypertension. This is when they have blood pressure elevated after 20 weeks gestation, but without proteinuria. May progress to preeclampsia or a chronic hypertension. Preeclampsia is when you have high blood pressure that's greater than 140/90 and that there's protein in the urine. Eclampsia is when there's high blood pressure, protein in the urine, and the patient has seizures. Chronic hypertension is with high blood pressure, which they know before pregnancy and or does not resolve during the postpartum period. We never treat any of these hypertensions with diuretics or ACE inhibitors during a pregnancy. Alright, so we're going to discuss preeclampsia. Preeclampsia is the result of generalized vasospasm, which results in impeded blood flow and elevated blood pressure. As a result, circulation to all body organs, including the kidneys, liver, brain, and placenta, decreases. Glomerular damage secondary to renal blood flow allows protein to leak across the glomerular membrane, which results in protein in the urine. Decreased placental circulations results in infarctions, which are death of tissue from lack of blood supply that increase the risk for abruptio placenta and HELLP syndrome. In addition, the fetus may experience IUGR, intrauterine growth restriction, and persistent fetal hypoxemia. This one appears after 20 weeks. You can look at box 25.2 and see some of the risk factors. So we will talk about preeclampsia. To have a diagnosis of preeclampsia, you have to have a blood pressure of 140/90 or higher and proteinuria. The cause of preeclampsia is unknown. It always appears after 20 weeks. The risk factors are usually women over 35 or first pregnancy, African American, history of hypertension, kidney disease, and obesity. This is just a picture of a woman with facial edema related to preeclampsia. Next, we'll talk about the systemic effects of hypertension and preeclampsia. We'll talk about renal, liver, cerebral arteries, respiratory, musculoskeletal, and uterine/placental circulation. So with renal, you will see increased BUN, creatinine, uric acid. There will be damage to the glomerulus, so protein leaks across the glomerular membrane and spills into the urine. Fluid shifts to interstitial space. You will have a decreased urine output and weight gain of up to 5 pounds per week. So in preeclampsia, the liver there is decreased circulation to the liver, which impairs the liver function. So you will have elevated liver enzymes. Epigastric pain is the most common complaint. This can progress to very, very severe elevation of the liver enzymes to the point where you get into the HELP syndrome and the liver can actually rupture. So cerebral arteries, this is when you have vasoconstriction of the cerebral vessels, which lead to rupture of capillaries and cerebral hemorrhage. Signs and symptoms will be headache, blurred vision, spots. The woman will have clonus and become hyperactive, will have hyperreflexive or hyperactive reflexes. So with the respiratory system with preeclampsia, you may end up with pulmonary edema. That's when the pulmonary capillaries will also leak fluid, and fluid leaks into the lungs, resulting in pulmonary edema and dyspnea. Sometimes it presents as crackles, wheezes. It can go to CHF and or cyanosis. Alright, so next we're going to talk about decreased uterine placental circulation in relationship to preeclampsia. Alright, so you know with preeclampsia there's a lot of vasoconstriction, and you know that results in decreased uteroplacental circulation, right? We've talked about it. I've drilled that into your head that's not a good thing, okay? So when you have that, you're going to, with decreased placental circulation, one of the resultants are you're going to have small infarcts, and those are when there is necrosis or cell death, and that can increase the risk for abruption, which can lead to, they all kind of play together and lead into one or the other. A HELP syndrome, which can lead to DIC. You can have fetal IUGR, and the resultant of all of these is fetal hypoxia, which of course we want to avoid at all costs. Alright, so signs and symptoms of preeclampsia. Once again, preeclampsia is not predictable or preventable. Goal is early detection. You want to monitor the weight, blood pressure, urine protein, epigastric pain, and reflexes. Deep tendon reflexes may be very brisk, indicating cerebral irritability secondary to decreased circulation and edema. And clonus indicates cerebral irritability also. So on this slide we'll talk about treatment with mild preeclampsia. Usually the treatment is just at home. You want to have some activity restrictions. The patient can probably do some kick counts, monitor blood pressures, monitor her weight, check for proteinuria, encourage a diet low in sodium and fluids. Might probably do outpatient ultrasounds, biophysical profiles, and non-stress tests. Delivery is the only definitive treatment, but if fetus is immature, if she's in their earlier weeks, gestation, that is not ideal. We want to keep that baby in there as long as we can. So with severe preeclampsia, the lady is going to be on bed rest, and she will be hospitalized at this point, probably on IV medications such as mag sulfate, and very, very close monitoring of the fetus, of course. The only option at this point is going to be delivery, because if she has severe preeclampsia, she's not going to get better, and you're just putting the infant at greater risk at this point. And you want to watch for any bleeding under her gums, petechiae, any bleeding under the skin, that type of stuff. So we'll talk about magnesium sulfate. This is the medication that we use to treat preeclampsia. It is the anticonvulsant of choice. It is a CNS depressant. It is not an antihypertensive. Okay? Please remember that. It blocks neuromuscular transmission, relaxes smooth muscle, especially the uterus, which reduces vasoconstriction. Reduces blood pressure, which increases circulation to the placenta and the kidneys. It decreases the frequency of uterine contractions, so it's used for both preeclampsia and preterm labor. It is excreted by the kidneys, and we usually continue these women on the mag sulfate for 24 hours after delivery. So nursing interventions when a patient is on mag sulfate, quite often we'll have 2 IV lines in place. We're going to be doing close fetal monitoring. possibly having a Foley, so she does not have to get up. You're going to have her on bed rest, limit visitors, a dark room. Of course, use all kinds of safety measures. You want to monitor her for toxic effects of the mag sulfate, which would be confusion, a CNS depression like respiratory rate of less than 12, decreased O2 sats, oliguria, hyporeflexia, absent clonus, which we don't really want clonus to be there, hypotension, flushing, and sweating. And remember, the antidote for mag sulfate is calcium gluconate. So again, just to review, the therapeutic level for mag sulfate is usually between 4 to 8 milligrams. You need to monitor for toxic effects of this drug. It's very, very important. When a patient is on mag sulfate, they're always on a 1-to-1 for sure. So you want to watch for any confusion, decreased respirations, oliguria, hyporeflexia, hypotension, and flushing and sweating. So when a patient's on mag sulfate, we always have calcium gluconate at the bedside and ready to be given immediately if we suspect a toxic level of it. We'd also use antihypertensives like hydralazine or presaline as a vasodilator to increase blood flow. Remember, mag sulfate is not an antihypertensive. Potential complications of preeclampsia are seizures, mag toxicity, or the HELP syndrome. We'll talk about the HELP syndrome coming up here, but what we want to avoid with preeclampsia is seizures. Once a patient has a seizure, then she becomes eclamptic. So eclampsia, this is again the addition of seizures onto preeclampsia. You'll always want to pay attention to safety. You want to turn the patient to her left side, put oxygen on her, monitor whether she's having any contractions or spontaneous rupture of membranes, and always use padded side rails on these ladies. Remember that seizures stimulate uterine activity, so you want to manage pain. You want to consider inducing labor, especially if maternal or fetal condition deteriorates. Always use 1-to-1 nursing care. So if you induce, you're going to have her on Pitocin and mag sulfate and continuous external fetal monitoring. Vaginal birth is the first choice because of depression of coag factors and other surgical risk factors. So remember aspiration of gastric contents is a leading cause of maternal morbidity, especially after an eclamptic seizure. So we want to avoid seizures at all costs. So next we'll talk about HELP syndrome. Preeclampsia can progress to what's called HELP syndrome, and that is the HELLP stands for hemolysis, elevated liver, and low platelets. So the hemolysis is when erythrocytes get damaged as they pass through small diameter blood vessels, which leads to hyperbilirubinemia and jaundice. The EL is the elevated liver enzymes due to fibrin deposits creating hepatic blood flow obstruction. And then low platelets, thrombus formation at areas of vascular damage from vasoconstriction. Remember, the most common reason for the mother to become critically ill or die secondary to severe hypertension are liver rupture or a stroke, either from cerebral edema or a hemorrhage. These may be prevented when caught early on. HELP syndrome may occur during the postpartum period, along with in the antepartum period. And again, as with preeclampsia, the cause is unknown. So symptoms of the HELP syndrome are usually there are a series of symptoms that make up a syndrome. It's often misdiagnosed. And remember, treatment is delivery. So if this happens in the antenatal period, you want to get this woman delivered as soon as possible. So you will have right upper quadrant pain, pain in the chest or epigastric region due to liver tenderness, hyperbilirubinemia, and jaundice may occur, nausea and vomiting and severe edema. They may feel like they have the flu, and then you're going to have labs. You're going to have decreased red blood cells, decreased platelets, and increased liver enzymes. chronic hypertension. This is usually when you see hypertension before the 20 weeks of a pregnancy. Sometimes they have it just before they're pregnant in general. Risk factors are older women, obese, and African American are at greater risk for chronic hypertension. Treatment is with an antihypertensive that will not diminish placental blood flow. Aldomet is the drug of choice. Beta blockers are next. ACE inhibitors are contraindicated because they reduce placental blood flow, and diuretics are avoided because they may further reduce blood volume. Alright, next we're going to talk about disseminated intravascular coagulation, which is also known as DIC. Remember, this is a complicated disease process to understand. Alright, we will talk about it more in the classroom also. But DIC develops when the clotting factor thromboplastin is released into the maternal bloodstream. And that is because of the placental bleeding and consequent clot formation. The circulating thromboplastin activates a widespread clotting in small vessels throughout the body. In DIC, the body's natural ability to regulate blood clotting does not function properly. This causes platelets to clump together and clog the small blood vessels throughout the body. This excess clotting damages organs, destroys blood cells, and depletes the supply of platelets and other clotting factors so that the blood is no longer able to clot normally. This often causes widespread bleeding both internally and externally. So DIC will be precipitated by cellular damage from infection, inflammation, ischemia, direct trauma, cancer, and pregnancy complications. Obviously, that's what we're talking about in this part of our PowerPoint. DIC as a pregnancy complication can happen with a fetal demise after the first trimester when there is a retained fetus. It can happen with an abruption, or it can happen with gestational hypertension. So again, you will see DIC and OB if you have an acute hemorrhage, placental abruption, preeclampsia, which can lead to eclampsia, which can lead to HELLP syndrome. A retained stillbirth, septic, abortion, intrauterine infection, amniotic fluid embolism, or acute fatty liver of pregnancy. Okay, again we'll go over the pathophysiology of DIC. So there is placental bleeding and clot formation, which causes thromboplastin, which is a clotting factor, to be released into the bloodstream. So now you have clotting in small vessels throughout the body. So then all your fibrinogen and platelets get used up, and then it activates the fibrinolytic system to lyse or destruct the existing clots. So then there will be simultaneous decrease in clotting factors and increase in circulating anticoagulants. So now the circulating blood is unable to clot. Bleeding can occur from any site, and you can have ischemic thrombosis may occur. So with DIC, the lab results that you're going to see, the fibrinogen and the platelets will be decreased. PT and PTT will be prolonged. A definitive diagnosis of DIC is a positive D-dimer. All right, typically that should be negative. D-dimer is a specific measurement of the fibrin degradation activity that may be ordered. Fibrin degradation is a component of the blood produced by clot degeneration. So priority treatment of DIC during pregnancy is to deliver the fetus and placenta. You want to stop the production of the thromboplastin. Treat the underlying source of bleeding, prepare to transfuse, apply oxygen, and at some points, some physicians choose to give heparin. Next, we're going to go back over RH incompatibility. I know we've talked about this a lot. This is when blood mixes between the mother and the fetus, and the mother becomes sensitized and makes antibodies against the RH antigen. Later, these antibodies may cross the placenta and attack future babies' fetal red blood cells. Management and prevention. You're always going to check blood type on the first prenatal visit. You will give RhoGAM at 28 weeks gestation to any woman that is Rh negative or at any time she has any bleeding throughout her pregnancy. Remember, RhoGAM prevents the immune system of the mother, who is Rh negative, from attacking the red blood cells of the baby, who is Rh positive. Alright, so next we'll talk about pregnancy with diabetes. So remember, insulin requirements decrease in the early pregnancy, usually in the first 20 weeks, and they will increase in the later part of the pregnancy. So after 21 weeks to birth, the insulin requirements go up. You may end up doing carb counting with pregnant women. Alright, so when you have pregnancy with diabetes, this is a very big deal. Every patient should have a diabetic educator, and they should be tested between 24 to 28 weeks gestation to see if there's any gestational diabetes going on. During labor, they may need a continuous insulin infusion. Postpartum, the insulin needs decrease rapidly. This slide just talks about ideal levels, and again, this is going to depend on each physician, each facility. You don't have to have these absolutely memorized, but before a meal you want her blood sugar to be around 60 to 90. 2 hours after the start of the meal, less than 120, and before bedtime or bedtime snack, somewhere between 80 and 120. Okay, on this slide we're going to talk about effects of diabetes during pregnancy. With maternal, she can have ketoacidosis. This is a huge threat for women on insulin because of the lower threshold, as low as 250 during pregnancy. Left untreated, ketoacidosis can be fatal to both mom and baby. Preeclampsia is more common. This does happen quite often with diabetic patients. They will have more UTIs. They will have hydramnios. This is from fetal diuresis, which distends the uterus and can lead to early spontaneous rupture of membrane. Macrosomia. This is caused by the excess of fetal secretion of insulin, which is a potent growth hormone, which can end up in a shoulder dystocia. So macrosomia, remember, is a large fetus, bigger than 8 pounds, 13 ounces, or 4,000 grams. And again, we talked about shoulder dystocia is a maternal effect, which also is an effect on the newborn. With the fetus, you have a risk of a spontaneous AB, risk of neurotube defects, macrosomia, which we talked about, and IUGR. So if you have both diabetes and preeclampsia both, there may be a decreased placental perfusion, so supply of oxygen and glucose is decreased, resulting in IUGR. Neonatal effects of diabetes can be hypoglycemia, hypocalcemia, hyperbilirubinemia, respiratory distress syndrome. So diabetes in pregnancy is considered high risk. When a patient is diabetic, they'll usually have twice as many prenatal visits. You want to monitor their weight gain, check for urine and protein, check their urine for protein, glucose, and ketones, and you want to keep an eye on their hemoglobin A1C. Not so long ago, physicians were advising pregnant women not to get pregnant. Now it is possible due to tighter glycemic control and to have a healthy pregnancy and delivery. Again, the effects of diabetes are all based on the degree of glycemic control. So education is huge for these women, trying to get them to understand the disease process and what will be most healthy for outcome for them and their baby. So diagnosis of gestational diabetes. You do a glucose challenge initially, and this is somewhere between the 24 and 28 weeks. You drink 50 grams of oral glucose. You draw the blood within an hour of that. If it's 140 or greater, then you have to do the 3-hour test, the GTT. That is a glucose tolerance test. And then you drink 100 grams of oral glucose, and then you draw your blood, or you have your blood drawn at 1 hour, 2 hours, and 3 hours. And you will be diagnosed with gestational diabetes if your blood draws are higher than any of these levels shown here. Remember, gestational diabetes is only during pregnancy. So management of diabetes, again, dietitian consult, small frequent meals help avoiding overeating. Exercise is so important. It improves metabolism of the glucose and helps the muscles for labor. So nursing interventions, you need to be a good listener, teaching of injection sites, insulin onset, peaks and duration, hypo and hyperglycemia signs and symptoms, and a referral to a diabetic educator. So next we'll talk about cardiac disease with pregnancy. Classifications of heart disease in pregnancy. You can see the 4 different classifications there. These classifications are based on the ability to tolerate exercise and the effects it has on the heart. Once the diagnosis has been made, then the severity of the diagnosis of the disease is diagnosed. So the main goal with cardiac disease during pregnancy is to prevent additional workload on the heart, leading to decompensation. You want to promote health for mother and fetus and have a safe term pregnancy and delivery. So these will be elevated with cardiac disease in pregnancy: heart rate, stroke volume, plasma volume, venous return, and cardiac output. So for class 1 and 2 cardiac disease, you want to limit activity, avoid excessive weight gain, prevent anemia, prevent infections. You want to always do assessment for signs and symptoms of cardiac or congestive heart failure, which we'll talk about on the next slide. Avoid emotional stress, extreme temperatures, and no smoking or drugs. So signs and symptoms of congestive heart failure, which I know you guys have just studied with Darcy. But just to review: cough, progressive dyspnea with exertion, orthopnea, pitting edema of legs and feet, heart palpitations, progressive fatigue or syncope with exertion. Most rales in the lower lobes, which indicates pulmonary edema. Normal cardiac function is able to adapt to the added demand on the heart, but with an already compromised heart, these changes can be a burden. It can lead to cardiac decompensation. If the heart is compromised, it can lead to congestive heart failure, which is failure of the heart to maintain adequate circulation. So mitral valve prolapse is the most common cardiac condition of the general population. They may be asymptomatic, but with this condition, the woman should be treated with prophylactic antibiotics before and during labor, and before any dental surgery or any other kind of surgery, due to risk for bacterial endocarditis. So class 3 and 4 cardiac disease, obviously you want to prevent decompensation. The maternal risk greatly increases with class 3 and 4. In addition to the already above listed management, you're going to put them on bed rest. This is a priority to protect the fetus from hypoxemia and decreased uteroplacental perfusion. Medications, these need to be assessed to weigh the risk versus the benefit: antithrombotic stockings and anticoagulation. So intrapartum management of a patient with cardiac disease: careful use of IV fluids, monitor vital signs. Left side is optimal position. You want to provide oxygen. Carefully consider an epidural use. Vaginal delivery is preferred. You want to minimize Valsalva maneuver, so use of vacuum or forceps, or just laboring down during the second stage. You don't want to rush the third stage. Let the placenta separate on its own. Change positions slowly, and again, monitor for fluid volume overload. So you want to constantly be assessing. You want to auscultate lung sounds throughout labor, ongoing. Auscultate for crackles, assess for signs of circulatory overload, bounding pulse, distended neck veins, and peripheral veins. In the postpartum management, you want to observe closely for infection, hemorrhage, or thromboembolism. These 3 can easily lead to heart failure very fast. So anemias in pregnancy is what we're going to discuss next. So there's iron deficiency anemia, folic acid, and sickle cell anemia. So with anemias, you have the decline in circulating red blood cell mass, reduces the capacity to carry oxygen to the vital organs of the mother or fetus. Significant maternal anemia is associated with preterm birth and low birth weight. Hemoglobin below 11.8 is considered anemic during pregnancy, and again, all facilities differ on their exact lab values. So iron deficiency anemia. The maternal effects, you'll see pica. This is when your pregnant woman has the desire to eat like clay, dirt, ice, things that normally people don't eat. She may be pale, fatigue, have small red blood cells, and have a low plasma iron. There's usually fetal effects. Usually the fetus is fine and has no long-term effects. Folic acid deficiency anemia. Folic acid is a vitamin B. These requirements double during pregnancy. Folic acid plays an important role in the production of red blood cells. Folic acid helps the neural tube develop into the brain and spinal cord. Neural tube defects are birth defects of the brain and spinal cord, which are usually found with iron deficiency. Diet for folic acid: beans and dark green leafy vegetables. Supplement 400 micrograms while childbearing age and 600 micrograms when pregnant. So anyone before they are pregnant, you recommend a minimum of 400 micrograms, but once they become pregnant, at least 600 to 800 micrograms. And if a woman has had a previous neural tube defect on one of her previous pregnancies, then she should even increase it a little bit more. So fetal effects of the folic acid deficiency anemia. Lots of times they might just end up in a spontaneous AB or a miscarriage, an abruption, or the fetus might have the neural tube defect, as you can see a picture of right here. Next we'll talk about sickle cell anemia. With sickle cell, you have red blood cells that are shaped like the letter C. They clump together and tend to occlude smaller vessels. It causes pain and infection, which can lead to organ damage and stroke. If you have a sickle cell trait, if you have the sickle cell trait, you have one parent that has the disease, then you are a carrier. To have the sickle cell disease, both parents have to have this disease for a child to get this. The main nursing intervention and care is to maintain oxygenation and prevent dehydration during labor. This is so very important for these women. There is a high incidence of preeclampsia with women who have sickle cell, 14%, and the incidence of fetal loss is high if there is a crisis, a sickle cell crisis during a pregnancy due to the loss of exchange surface of the placenta due to infarctions. So again, we want to avoid any type of sickle cell crisis with a pregnant patient. So with sickle cell anemia, the maternal effects are a sickle cell crisis, and she also has a greater chance of pyelonephritis, bone infections, and heart disease. The fetal effects, if a mother has sickle cell anemia, there will be no problems if there is not a sickle cell crisis. It can lead to IUGR or fetal death related to placental infarction. Again, those two is if there is a crisis. On this slide, we'll talk about seizure disorders with a pregnancy. This is considered a high-risk pregnancy. The major concern is the teratogenic effects of the anticonvulsant medication. It's always recommended to consult with a neurologist before conception, and if seizures during the pregnancy, fetus may suffer from hypoxia and acidosis. So again, you have to look at the medication that the woman is on to prevent seizures, whether the effects of that seizure medication is beneficial to keep that woman from having seizures versus the damage it can do to that fetus.